Thank you for having me. Thank you so much. I hope that hopefully the introduction wasn't too boring. People started burning for the exits with your very elaborate introduction. So I appreciate it. And I'll just start by saying it's an honor to be asked to participate. I have had experience with SBH and SBH Fertility for the last couple of years. I forget exactly how long ago I really got connected formally. And you guys do really an incredible job. I mean, I'm obviously not in the Sephardic world, but I have a lot of admiration for how you guys take care of each other, and really the community spirit is something that I think other communities can only hope to emulate. And in particular, the SBH world and the SBH fertility world is more, I'd say, even aggressively kind than other sort of support organizations that I've seen in the past. So really keep up the good work. And again, it's my privilege to be asked to participate.
Thank you so much. So should we jump in?
Let's do it.
Okay. So what is secondary infertility? And how do you know you have it?
Yeah. So, the main headline with secondary infertility is that it's not, the way we think about it is not all that different than primary infertility, meaning definitionally anyone who's had a pregnancy in the past and is now struggling to get pregnant again is what we call secondary infertility. Some would say that requires having a baby before. Others would say that even a pregnancy that did not lead to a baby, meaning a miscarriage, counts. Doesn't really matter how we define it, but it's basically the concept of struggling to conceive after a previous pregnancy. And typically, the book would define struggling to conceive as a year of trying unsuccessfully for women who are under the age of 35, and 6 months of trying to conceive without success for women who are over 35. And so there's sort of a reduced threshold to be considered someone who is called infertility for women who are older. And we'll talk more about age as part of the story here, I think, as we go along.
But would you ever recommend for someone to call before that time period?
Yeah, so I think two important points to make on that. One of them would be relevant to primary infertility as well, which is when we say trying for 6 months, trying for a year, historically, fertility efforts are measured by month because most people have a monthly cycle, which basically means that most women ovulate 1 egg per month, and that gives them one opportunity each month to get pregnant. So really, the truth is we should be more talking about opportunities, right? So for most women, if you're younger, we can wait 12 chances if it doesn't work out. If you're a little older, usually we want to be more aggressive and only wait 6 chances. But my point is, if someone does not have regular menstrual cycles, for example, so they're not getting regular opportunities, so they can wait 10 years, but if they're not getting opportunities to get pregnant, it's not going to be a shocker if they don't. So one huge exception to the how long should you wait rule is if you don't have regular cycles, that you should have obviously an easy ability to clarify how your cycles are, then there's no reason to be holding to this 6 months or 12 months rule. And the other larger commentary is that this is assuming that on the surface things seem healthy and normal. But if someone has any particular history, so for example, if someone knows, let's say they have something called endometriosis, which we know can be associated with fertility problems, it doesn't mean that they're sort of obligated to go ahead and try for 6 months or 12 months before they should talk to a doctor. So it's almost like if we assume everything's fine, then we can use those guidelines. But if there's some obvious or semi-obvious issues, we probably don't need to be so patient, essentially.
So what is the normal cycle length then? What would you consider?
So the parameters for normal is a cycle doesn't have to come every 28 days on the nose. So the book would say every 28 days is sort of the most normal, but it would also say that too close together would be cycles that are coming more frequently than every 25 days, and not frequently enough, cycles that are far apart is coming more than every 35 days. So 25 to 35 is sort of the parameters of normal. One thing I'll throw out there, especially in this context, and this isn't something that's specifically related to secondary, although it can be, is that timing can be particularly important for women who do Taharat Mishpacha and that wait to go to mikvah to be together with their husbands. Basically, there is such a thing as what we call halachic infertility, which is if a woman has a short cycle and ovulates early, she can miss her fertile window if she's not with her husband until later in the month. And so particularly for women with shorter cycles, that's definitely something to be aware of and to be thinking about. And there's ways to deal with it. So there's definitely room to maneuver without doing necessarily anything too major to fix that issue. But that can be an issue that definitely can come into play.
And then do you ever see a cycle length change after having kids? Like someone
So
has a normal cycle, has their first child, and then after giving birth, their cycle completely changes.
Yeah, so that's a really I think hit the nail on the head kind of question, because it's very common for women's cycles to change through their reproductive lifetime. Sometimes those changes are important and meaningful. Sometimes they're not, meaning it's not necessarily a problem if a woman's cycle changes to some degree from her 20s to her 30s to her 40s. But there are times when it does matter. And so one of the more typical themes, one of the more typical patterns that we see is that cycles often will get closer together as a woman gets into her late 30s or 40s. So it's common knowledge that age matters a lot when it comes to female fertility. And one of the ways that age matters is that as a woman gets older, her egg supply is decreasing. And as the egg supply decreases, that often causes the cycles to shorten, to come closer together. So it's actually, in a certain way, normal for women, let's say in their late 30s or early 40s, to see cycles start to shrink, but it can cause trouble. And sometimes that's a sign of trouble if that's what's happening.
Oh, that's very interesting.
Yeah.
Okay.
And then I guess since I'm on the topic, I'll just add also that, one of the inherent issues of secondary infertility is that it is, by definition, infertility that comes later, right? And so coming later means that you're older. Now, of course, it doesn't mean old, but older. And so one of the most foundational things to think about if a couple has had an easier time getting pregnant in the past and is now not having an easy time is, to what degree does age matter? And I already mentioned a minute ago the idea that egg supply can decrease and that it can cause some changes in the menstrual cycle. But there's another sort of silent issue with age, which is the quality of the eggs. Egg quality universally gets worse as a woman gets older. So it is understood and really expected that someone who's trying to conceive in their 20s should have an easier time, and it should happen quicker than someone who's trying to conceive in their 30s or 40s. The bad news is that that's not an issue that's easily fixed. In fact, we can't really change that. The good news is that we still have treatments that we can use to try to overcome that. But that's an inherent piece of secondary infertility, that you're by definition older today than you were the last time you got pregnant, and that could be playing a role.
So now let's say someone has a normal cycle length and they've been trying for, like you said, a year, or if someone even has a short cycle length or an extended cycle length and they've been trying, like when should they see a fertility specialist?
Yeah, so I think the rule of thumb is really, to be honest with you, that we don't want people running to the doctor if they don't need to, because it takes time, it takes effort, it takes money, and it causes a lot of anxiety. But at the same time, if you're paying attention to your cycles and it's been some number of months, whether that's 4 months or 6 months or 8 months or 12 months or more, it generally is probably worthwhile to do a visit with a doctor to just quote unquote check things out, because at worst, hopefully if it's a doctor that that you trust.
A fertility specialist or with your regular OB/GYN?
That's a good question, and I think the answer is it depends on the OB. Some OBs are much more comfortable dealing with the sort of surface level of fertility stuff, and some kind of just would rather, the minute you mention the word fertility, send you off to a fertility specialist. Yeah, I kind of have to know your doc a little bit, or maybe broach the topic with them. But there's nothing wrong with getting some basic testing done in an OB/GYN if they're comfortable to kind of wade into those waters. Excuse me. Basic testing usually can look like the following. Typically, if you go to an OB or a fertility specialist to get some sense of whether there's some obvious explanation of what's going on. So number one, the most important thing in a certain way for secondary is the story, right? Meaning the doctor should talk to you about, okay, how many times you've been pregnant before? How easy or not easy was it to get pregnant before? Of course, did you need any treatments to get pregnant in the past? But also to think about what has potentially changed in your health that might explain a difference. And there's lots of things that can change over time. General health things like whether a person is the same weight if a woman or a man, for that matter, actually has gained or lost a very significant amount of weight, that alone can sometimes cause an issue with fertility. It's actually maybe this is going to be less common because of like Ozempic and, medications that help with weight loss, but bariatric surgeries that cause a tremendous amount of weight loss, they can mix up your system, both on the female side as well as the male side. And even though for the most part, people who lose a lot of weight are healthier people after they've lost all that weight, but hormonally, sometimes that can kind of cause a ruckus in the system, and the body can either shut down the cycles, or for men, it even can interfere with sperm production. So like I've had patients over the years, and this might sound weird, but it's a real thing, where they have, 1 or 2 or 3 kids, and then the guy at some point does bariatric surgery, loses 100 pounds, and then all of a sudden they can't get pregnant. And then over the course of time, eventually we do a sperm test, and turns out his sperm count is really, really worse than it used to be, or than it's presumed it used to be. And that's the issue. Now, that's not super common, but I've seen it numerous times, not just once. And so the main point basically being that general health overall supports fertility health. And so anything that affects, or I should say that changes in a person's health, whether it's weight or lifestyle or other health issues, blood pressure issues, cholesterol issues, surgeries can be very important. These are things that everybody's health gets more complicated as you get older because stuff happens. And we can talk more about that, particularly on the female side. But basically, that's the first step of the evaluation, is to sit with a doctor and kind of go over what's the state of my health and of my husband's health, and what might be different today than it was, years ago when we were able to conceive.
Well, let me ask you a question that I know a lot of girls, their first question, right, when they're trying for 6 months to a year, they go to their OBGYN and they say, can I just get some Clomid? That's like I did the same thing. I got pregnant at first.
Yeah.
I'm trying. Actually, like with my second, right away, I just wanted to be pregnant. I went to my doctor and I said, can I just get some Clomid?
Right.
So,
and yeah,
I took Clomid for 4 months with no results, thinking like I thought it was going to work in a second.
Yeah.
Because I was pregnant with my first.
Yeah.
And month by month, nothing was happening. I finally went to a fertility specialist, and he told me that I wasn't being monitored, so my lining was too thin on the Clomid, and I was never going to be able to get pregnant. So what do you say to someone who comes and asks you if they could just try Clomid? Yeah,
so I mean, the joke is Clomid. So for people who don't know, Clomid is probably the oldest and most popular fertility medication out there. It's spelled Clomid, Clomid. And so the joke is that it's vitamin C. You just give it out like it's nothing, like it's candy. Many, not all, but many OBGYNs are very liberal with prescribing Clomid. And the truth is, it's not a crazy thing to do, because there are plenty of women who will just take some Clomid and will get pregnant within a month or two. So there are certainly success stories. But on the other hand, there's definitely the, I think, deeper consideration that Clomid does have some risks, and it's not a magical fix, right? So what Clomid does is the following. For women who are not ovulating regularly, it can induce ovulation. It can cause them to ovulate. So you can go from someone who doesn't have a chance to get pregnant because you're not ovulating to someone who does have a chance to get pregnant. So that's one way it can work if you don't have regular cycles.
But even some girls that have regular cycles, like me, I was regular. Everything was normal.
So the room for it to work is less when you already are ovulating. So it's not wrong to use Clomid if you already have a regular cycle, and we do that as well. But we just want to be clear-eyed about what we're doing and why we're doing it. So if you take Clomid, even if you already have a regular cycle, what it's doing is basically inducing, if it works, a second or a third egg to grow at the same time, which is basically gambling, right? You're basically taking a month that normally only gives you one opportunity, and you're squashing in 2 or 3 chances for pregnancy within the same month. It can help, but it also can, of course, end up with twins or even triplets. The Clomid that a fertility specialist would prescribe is certainly the same Clomid that an OBGYN would prescribe. The difference is usually, A, we're more comfortable doing a detailed evaluation to make sure that it makes sense to be giving the Clomid. And B is that we always do monitoring, which means we torture people by doing ultrasounds and blood work to follow along and make sure the Clomid is doing what it's supposed to be doing, and not causing something like a thin lining, like you're mentioning, which can sort of, ambush the whole potential benefit of it. So there's no doubt that, you know, in a perfect world, doing Clomid with a specialist is going to be more likely to work than with an OBGYN. But, you know, I'm biased and we are spoiled. We only do this and the OBGYNs do a lot of other stuff. So it's not inherently wrong for an OBGYN to give somebody Clomid. It's just you have to kind of know the parameters, the limitations of what that could look like.
So even if Clomid worked on a first pregnancy, it doesn't necessarily mean it'll work on the second pregnancy. It could have different effects.
That's for sure correct, yes. Just like in general, the system can work differently.
Completely.
Say that again.
That's what happened with me. I took it with my first. It worked the first month.
Yep.
But went on it right away trying to get pregnant my second and had the opposite effect.
Yeah, I'm not sure if we should be surprised or not surprised, but there's no doubt that, you know, using even the same medication in the same person, but if you take them, you know, now versus 3 or 4 or 5 years later, after a pregnancy, after whatever life changes have happened, you know, it's not going to be always lead to the same place. And so, you know, the instinct is totally understandable that if you took it before and it worked, take it again, you know, same medicine, same thing. But in reality, it definitely may not have the same kind of benefits. And so it is definitely worthwhile to be a little bit more circumspect, meaning to do, if possible, the basic testing, and also kind of, if possible, to do the monitoring so that we know, you know, what's working, what's not, and they're able to adjust to make sure that we're giving people the best possible chance.
Got it. Okay. So now you're sure that someone with secondary infertility, you have to go through all of their changes, what changed from the first pregnancy to the second pregnancy. So a lot of women will ask, but I had a child, I had a baby. What could have changed? I don't understand. Like, I got pregnant on my own.
Yep.
What are some that can happen?
Yep.
Besides
so
the weight loss and
right. So we touched on a couple things already. So general health changes matter, or they can matter, weight being the most general of all health things, but also things like new medications that someone might be taking today that they weren't taking years ago, or surgeries. So one of the most common surgeries that can affect fertility is one that is in the world of OBGYN, which is C-sections. The idea is that any surgery, when the body heals, so surgery essentially by definition means kind of penetrating or cutting some tissue to get where we need to go to do something. So anytime that we open tissue, that we cut tissue, it has to seal, it has to reclose. And when the body allows things to heal like that, there's almost always going to be some degree of overhealing, and we call overhealing scarring. And so scar tissue can be something that directly impacts the ability to conceive, particularly when it affects the fallopian tubes. The fallopian tubes are these little pipes that exist on the sides of the uterus that basically allow the eggs and the sperm to connect. They are notoriously small and delicate. And so scarring from any kind of surgery, including a C-section, can affect the fallopian tubes in a way that can make it more difficult or even impossible to get pregnant.
Sorry for interrupting. It could cause blockages.
Correct. It can cause scarring that can lead to a closure of the fallopian tube, or blockage of the fallopian tube that makes it harder to get pregnant. Now, I just want to be clear and not to scare people. It's not like, you know, there's a 50-50 chance if you have a C-section, you're going to have scarring. It's not that common that it causes trouble. But if there's a situation of secondary infertility and the patient had, you know, let's say 2 babies and the second baby was a C-section, now all of a sudden she's not getting pregnant, that's going to be right up there in the top 5 potential reasons why they might be having trouble. And it's definitely something that has to go on the list of, you know, rule it out. You need to be tested to see if there's scarring that's affecting the tubes. How do we look for scarring that's affecting the tubes? There's an X-ray test called HSG, or hysterosalpingogram, which is basically usually done by a radiologist, although some fertility doctors also will do it in their office. And it's basically a test where we put an X-ray dye, DYE dye, of fluid through the fallopian tubes to check if the fluid is able to pass through. And if there is a blockage, the fluid will get stuck, and we can see that on an X-ray. And that's the sort of classic test to look for scarring. There's another issue that C-sections can sometimes cause, which I'm seeing more and more of even in my own career, even in my own practice, as more, I mean, C-sections, for better or worse, have become super duper common, which is there's something called a C-section niche, which means that the area where the uterus was opened, at the bottom part of the uterus, can sometimes heal with like a little indentation, and you can have fluid or mucus or even blood that collects in that little indentation, and that can also sometimes interfere with pregnancy. And there are surgeries that can be done to correct that type of defect, that C-section niche. That's a specialized topic. We could talk more about it, I think, in a more a narrow session. But
Yeah.
point basically being that C-sections are definitely, you know, top 10 things to think about for secondary infertility in different ways.
Okay, so now if somebody is trying and now it's the 6-month mark, so the year mark, they come to their first appointment, what can they expect? What will you be checking on that at that first appointment?
Yeah, so to go in order always, we try to do diagnosis first and then treatment second, meaning the first general project is to try and get a better sense of, is there an identifiable problem that we can put our fingers on to say this is why it may be harder to get pregnant, and that by doing that we can direct the treatments to try to target what's wrong. And so again, the first part of diagnostics is taking the history, right? Asking about these things that we're talking about, health issues, pregnancy issues in the past, new medications, surgeries, both again, and let's not forget about the guys, because they're
Right.
they're half the battle here.
So that's what I was going to ask you. At what point should the male be tested?
Yeah, so that's a sensitive subject, because the reality is that if you ask any fertility doctor in the world outside of like the Jewish world, they're going to say at the beginning, the first step, there's no reason to delay that. And the truth is, they're right. Medically, it's very common that a male factor, maybe it's not a complete male factor, but maybe it's a partial male factor, may be affecting the chances of pregnancy. And so there's really no scientific reason why we should necessarily wait to check the man. I think culturally, psychologically, men assume that female or that fertility problems are generally female problems. And, you know, look, there are lots of female problems, but there's also a lot more male problems than men usually are aware.
So should the men be tested at the beginning while the woman's doing the sonogram and the blood test?
So if you speak purely medically, the answer is there's no reason not to. Having said that, you know, ask your local rabbi, because from a rabbinic perspective, from a Jewish perspective, there is a Jewish question of, you know, the appropriate way to approach checking a man's fertility. And depending on who your rabbi is, they might give you slightly different advice. But definitely some rabbis will say, from a Jewish perspective, it makes sense to start with some of the more basic testing on the female side before we do testing on the male side. That is, again, a subject that is sensitive, and that you're going to get different guidance from different rabbis. But it's something that I think, you know, if you're in the habit of asking your rabbi questions, then it's probably something you should present. But again, if you go to any fertility specialist in the world, they're going to say, yeah, do it right away, because it's better to have at worst, if you check the man's sperm situation and it's good, so then we know it's good and we can move on.
We know most of the men freak out a little bit. They have to go get tested.
Yeah, men don't love it, that's for sure.
So like, where is something like that done?
Yeah, so these days it's easier than ever, is the truth. So for the most part, to do a sperm test, well, actually, let me say it this way. A regular semen analysis is done in a fertility lab. Usually that's a lab that's associated with a fertility center. Technically, there are labs that are independent of a fertility center that can do a semen analysis, but to be honest, they may not do a great job. So usually you'd be doing it through a fertility center. There are companies these days that do these like mail away tests, and it might sound crazy, but a guy can produce a sample at home and like get the sample into a container and package it up in like a FedEx, and you send it off to them, and then they send you a report. Again, buyer beware, and ask your rabbi if it's something that he would approve of, but you could actually do the testing even at home. But usually it's something that you would be doing under the direction of some doctor, whether it's the OBGYN. By the way, OBGYNs can certainly order a semen analysis. There's no reason not to. Okay. Or the fertility specialist, and they'll usually give you guidance on how to accomplish that, you know, practically which lab they would send you to do that in or anything like that.
Gotcha. Okay, so now once the girl comes in, she does the blood work, she gets her sonogram done. If the doctor thinks that she does the hysterosalpingogram,
HSG.
Yeah, that. Okay. They do that. Is that painful?
It's not pleasant.
Yeah.
So HSG is a little bit infamous for being a tough test, because it's
rough. It was a rough one.
You did one. Okay. So you know.
Yeah, I had no warning how bad it would be.
So yeah, we usually encourage people to take like a couple of Advils or something like that beforehand. It's crampy and it's a little uncomfortable, and you know, again, it's not like medieval torture, but it's not the most fun test, that's for sure.
So after we do all that, you either find a diagnosis or it can
Or
be
not.
unexplained,
Correct. That's right. So
which is
the diagnosis.
likely, right?
Yeah, so the diagnostics are like turning over. It's like we're playing a game of cards here, and by doing the diagnostics, we're turning over the cards. Okay, this is the male card. How did we get a strong card there or not? This is the ovulation card. Are we in good shape there or not? This is the anatomy card. Do we look like we're okay there or not? And if we find something that is a red flag, right? If there is an issue with the sperm count, or if there is an issue anatomically, then of course the recommendations about how to deal with it are going to be targeted towards trying to correct that issue. But as you're saying, very appropriately, many couples, probably at least 1/3 of couples, we're going to turn over all the cards and
Nothing.
we're not going to find anything specific. And so
It's the most frustrating.
Yes, well, secondary infertility that is unexplained is probably the most intellectually and maybe emotionally frustrating subcategory of fertility.
Yeah.
Because basically, not only is unexplained infertility in general hard, because what do you mean there's no answer? Like, we just don't know. But even more so for a couple that has had a pregnancy in the past and now something changed and they're not, it's particularly extra frustrating.
Right, with no reason. And like, I had my kid already, I have a baby home, like, what is happening?
Correct. Correct. Yes, it's hard, and I sympathize with that, because we know that these two human beings as a couple are able to have a baby together, and yet now they can't.
Right.
It just doesn't make sense. But again, it's just the way it is. Unfortunately, that's a lot of the time that's the case. So how do we approach treating?
Right. What's the first treatment?
So it's hard to fix things when there's nothing broken, but what we generally do is basically give a nudge. What do I mean by a nudge? I don't know if they use the word nudge in the Sephardic world, but it's a big Ashkenaz word. So basically, we try to stack the odds in your favor by doing, usually as a first step, one or both of the following. We were talking before about using medication to give you more than one chance per month. And so Clomid, or the newer medication like Clomid, is called letrozole, or a stronger version of those medications are the gonadotropins, the hormone injections. Categorically or conceptually, those are all medications that do the same thing. If you already have a cycle, they give you more than one egg at a time. And I said before, it's gambling, and it is. But for whatever reason, sometimes it seems to push people kind of in the direction they need to. And so using medication to supercharge the chances by giving more than one egg at a time is a very common strategy to kind of start pushing things in the right direction. Usually when we're doing that, or I should say pretty much always when we're doing that, we are monitoring the cycle to see how many eggs are growing, to see that the things like the subtle things like the uterine lining looks healthy, to make sure that
like
typically with ultrasound and then also with hormonal measurements. So when we say monitoring, what that means for people who are, thank God, not used to it already, I guess, is basically during the course of a cycle, we ask people to come into the office, not for like long appointments, but for quick appointments, usually in the morning, to have an ultrasound done, to have a blood test drawn. And we're literally looking at the uterus and the inner surface of the uterus, uterine lining, which is the most fertility sensitive part. We're looking at the ovaries. We can see if the eggs are growing, how many and how fast. And then by looking at the blood work, we can see the hormone levels, and we know, of course, what should be going up, what should be going down. Like we know the patterns that things are supposed to be taking if things are progressing in a normal, healthy way. So
why is the uterine lining important?
Well, the uterine lining represents anatomically the place where, if there is an egg there and if there is a sperm there and they get together and fertilize, the next step is that they need a healthy place for them to, or for it to sit down and to kind of burrow into the uterus and to start growing. And a uterine lining needs to be healthy for that burrowing to happen. I have a patient who actually is sort of a distant family member who came to me secondary infertility. I think she had, I forget, either one or two children. And then she had a C-section and some other surgery. And then she was seeing another doctor and did, I think, either 2 or 3 IVF cycles and didn't have success. And she was kind of at a loss. And her mom, who was like a cousin or something, said, "Why don't you see me?" And basically, she had a persistently thin uterine lining, which for whatever reason wasn't recognized. And we ended up having to do a minor surgical thing, a hysteroscopy, which is what we do to try to, if there is sort of mild scar tissue that's limiting the health of the uterine lining, we can make it much healthier. And then we did an IVF right away after that, and she got pregnant the first try. And then the best part of the story is that a year and a half later, she called me up. We were going to plan another IVF, and in the process of preparing for another IVF, she got pregnant naturally.
Wow.
So it was clear that that uterine lining was sort of the source of the issue from all along. And so sometimes paying attention to those kind of subtleties can make all the difference as far as, you know, kind of getting people to the other side of the line. So, you know.
All right. So you do the medication, or you do injections. You're monitoring every few days.
Yep.
What if this doesn't? How long would you do this for?
So for one thing I'll just throw in there is that when you're doing medications, the other thing that's going to come up routinely is the concept of IUI. So IUI stands for intrauterine insemination. It's basically, so if you're doing a cycle of treatment with a doctor and you're taking medication and monitoring the cycle, then you can either do it with intercourse or do it with IUI. What do I mean? On the day that you're ovulating, which is the most fertile day, we kind of have a choice. Either we ask, or we instruct people, okay, you're ovulating, you know, go home and do your thing and be active, you know, tonight, tomorrow night, whatever the timing exactly may be. Or we can ask people to come into the office for this intrauterine insemination. What that means is that we get a sperm sample from the guy, and the lab processes that sample to purify it and to kind of condense it or concentrate it into a tiny little catheter. And we can take that little tiny catheter and advance it into the uterus. And by doing so, we can bring more of the sperm closer to where they need to get to basically stack the odds in our favor. Just like the medication can get more eggs, an IUI can get us more sperm in the right neighborhood at the right time.
So you're putting the sperm closer to the eggs to make it a higher process.
Exactly right. Exactly right. And so IUI is something that's very commonly done in the world together with medications. Once again, it might be something you want to ask your rabbi about because it relates to the male story, which is, again, sort of a loaded question with regard to Jewish considerations. But doing IUI is a very common thing to be done together with medications as well.
And what is the percent of that working? Like, what is the percent chance a month?
So, of course, it depends on the details. And like everything in fertility, age is in the background because someone doing whatever treatment we're talking about, if you're 20 or if you're 40, it's going to be very different success rates. But as a very rough answer to your question, in most settings, doing medication and IUI is going to be somewhere between a 10 and 20% pregnancy rate per month.
Not so high.
So not so high. But the truth is, keep in mind, and some people are surprised by this, but if someone is, let's say, in their 20s and normal and healthy and fertile, and they're just trying to get pregnant for the first time, they have no fertility history, nothing, the chance of natural conception per month is about 25%. So it's not like, you know, normal is 90 and we're talking about 10 or 20. Normal is maybe 20 or 25 and we're talking about 10 to 20. It's not great, but it's not terrible.
And
but
how many IUIs would you recommend a person doing before moving on?
So yeah, so there is some element of chance, meaning some eggs are no good, some sperm are no good, maybe the timing isn't exactly right, and then there's what we call mazal or mazel.
Right.
So we know that sometimes it can take 2 or 3 tries of something, even if it's a good strategy to get to the destination, to get to the goal. So we usually don't abandon ship if things look good, they just didn't work out, in fewer than 3 tries. But we also don't usually do things for more than about 6 tries because most studies would show that if you've done the same strategy for 5 or 6 tries and you still haven't had success, the chance you're going to find success beyond that is actually much, much lower. Not because something changes, like you run out of steam or something, but rather just statistically, if it was going to work, it should have worked in the first 6 tries. So the chance that it's just like mazel and that the 7th will work, it's not 0, but it's much lower.
Well, I want to throw out there also, I think it's important that everyone's like aware of what's going on as they go for all their appointments. Like when they go in for the blood work and the sonogram, just to ask questions and to make sure what the lining is, make sure that they're checking the lining, the doctor's checking, make sure your hormone levels are good. Because I did about 6 IUIs and switched to a second fertility specialist. When the minute they saw my chart, they said, this is exactly why none of them worked. Your lining was at a 3. In order to get pregnant, it needs to be, I think, what, a 7 or higher?
We like to see at least 6 or 7, yes, correct. Yeah.
So the whole time I was going to IUI over the course of almost a full year, trying to get pregnant, and it was all for nothing.
Yep.
So I think it's important for everyone just to be on and ask questions. Ask about the follicle sizes in the sonogram. Ask how many leading follicles there are, just so nothing gets lost. Like, and
Yeah.
nothing, everyone's human. There's mistakes that are made, but.
So I think I'll piggyback on that to say fertility is in a certain way very, very narrow, and there's only a very limited menu as we're talking about of different tools that we have available to us, whether it's Clomid or letrozole or IUI. There aren't like 100 different treatments to choose from, but there is a lot that goes into it, and details can matter. And so I think that to just emphasize or re-emphasize what you're saying, you know, in the world of fertility, it's usually people who are relatively young, relatively educated, relatively engaged in their care, right? Like we're not dealing with an old person who like just here's the prescription, take the medicine, don't ask questions, or a kid. Like you have every right to be engaged in your care, and so absolutely you should have clarity on, okay, what is our strategy? What do we think is going on? Why are we doing what we're doing? And why do we think it might work? And what are the reasons why it might not work? And if you're worried, like it doesn't seem to be working,
Right.
to ask the questions of, you know, to the doctor or why do you think it's not working? You know, you should never be shy to ask because it's your right. And if at a minimum, the doctor should say, well, I'm not sure, but I think it's reasonable to try. You know, like hopefully the doctors are willing to admit that we don't know everything. But it's never good to just be going blindly and saying, okay, the doctor said do this, and so I'm just going to do it. Because you're right, sometimes things get like on autopilot, and you end up doing this and this and this over and over again, and there's actually not really an active
and the office
process.
gets busy. Sometimes you get lost, and you just need to be on top of your own.
Yeah, I mean, not in our office, but you know, in
other offices.
right, everywhere else.
Yeah.
No, but it is true, and again, hopefully a good care team, a good doctor will never be, you know, will never be offended by if you're asking a reasonable question about your care. It's like totally fair game, you know.
Right. Okay. So now once someone maybe does 6 IUIs, that didn't work. Like in my case, it didn't. 6 IUIs. I went to another doctor.
Yep.
He wanted none of the IUIs were for any good reason because my lining was at a 3. But I've had it. I said I'm done. Let's just do IVF. I'm not even bothering with the IUIs anymore.
Yeah.
Is that your step after 6 IUIs?
Look, I mean, I think for one thing, and I don't know your whole story, but if it seemed very suspicious that maybe the lining is the issue, you could say, well, maybe then.
I think I tried maybe one more, and then.
Yeah, I was gonna say then maybe change the medications, do something to make the lining better.
Yeah,
and
I did injectables, and one more IUI, and.
So that sounds totally fair to me. But yes, at the end of the day, in the modern world of fertility, all roads ultimately lead to IVF, and that's sort of good and bad. Not everyone needs IVF. I want to say that like 10 times over because it's true. In fact, depending on the population, most people may not need IVF, but IVF is very powerful and it has a lot of success. It is a game changer type of treatment because it sort of cleans the slate and changes almost everything. That all the considerations are different. The general concept of IVF, I'm sure most people who are listening know, it's where we use the strong medications, the shots, the gonadotropins, to intentionally stimulate lots of eggs to grow, right? So in a non-IVF cycle, we're always nervous that if we give you more than 2 or 3 eggs at a time, that you might be the lucky one that ends up with triplets or whatever, and that's not like a healthy thing, and that's not what we're looking for. So we really cap the number of eggs at a low number to keep things safe. If we do IVF, we can get 10 eggs, we can get 20 eggs, depending on the person, we can get even more. And so we're really, really maximizing the amount of chances in one treatment. You know, if you get 20 eggs in an IVF cycle, that's like almost 2 years worth of chances all squashed into one treatment cycle. So that's part A, is that there's a lot of eggs that we're working with, or at least there may be.
So they're doing injectables. A
Correct.
person is doing injections every night?
That's right. So pills don't have the ability to get you more than usually 2 or 3 eggs, but shots it's sort of unlimited. You can get 10, 20, 30, and it requires the injections, which are small needles, but they are injections every night, typically for about 8 to 12 nights. It's not so long.
How many per night? About?
Usually 2 or 3. Mm-hmm. So that's part of the intent.
Where do you inject? Where does the person inject them?
So most people do it in the stomach. It's like a little needle. It's not some giant, scary thing. It's a little needle, and you just squeeze the skin of the stomach and you just prick the skin, and that's how the medication goes in. So I don't want to minimize it. It's not simple. It's not easy. And it definitely is scary if someone's never done injections before. But most people, once they kind of do it the first or second night, they get the hang of it. It's not like a scary thing. If people may know.
I want to throw out that SBH Fertility, if anyone needs, has nurses that are willing to help anyone that want them to do their injections for them. just give
Amazing.
us a call and we could set it up.
Wow, that
It
is
was
fantastic. Yeah.
my life. I went to someone's house every night. She kept my medicine in her refrigerator. I would go to her house. It was a little bit of comic relief, and she just made me feel better. And I just felt like I had someone like on my side.
I was about to say, I bet it's not just about the help with the
No,
injections,
it was
but it
honestly,
immediately gives you someone to support you and that understands what you're going through, and kind of
yeah,
has such a direct impact on your psyche of getting through. It's not, again, it's not a long, but you're not doing it for 6 months in a row. You're doing it for just a week and a half, 2 weeks, but it's intense. And of course, compound that with the fact that when you're taking those kind of strong medications, I would be remiss if I didn't point out that a lot of women, not all, but a lot of women, it makes you a little crazy, meaning their hormones, right? And they can definitely mess with your emotional stability. And so you're doing something that's already very deeply sort of emotional as it relates to your sense of self and sense of, your feminine ability and whatever. And then you compound that with the fact you're taking all these hormones, and it would make it crazy even if you weren't going through fertility.
and it's your life. It's every single night.
Yep.
You're breathing, you're pain.
Yep.
You're bloated.
So it's not, and it's not just the injections every night, but then we're also asking people to come in for monitoring very frequently. So it's usually about every other day that you're in the office getting, and not just, talking to someone, getting in the office, you're getting your blood drawn. So it's a lot of needle sticks, and you're getting internal ultrasounds, which are no fun either. So it's just a lot of probing and prodding, and like just not anybody's idea of a walk in the park. But it's doable. I mean, I guess you can attest. It's intense, and it's not easy, and it's not fun, but you get through it.
About it one day.
Yeah, and there you go. And once you get through that week and a half to 2 weeks of the injections, so then we do the egg retrieval, which is the procedure typically done under anesthesia while you're asleep. You don't feel anything. You don't remember anything. We take the eggs out using a needle. So it's not really surgery. There's no cut. There's no incision. There's no scar. But it is something that's invasive, and that we do give anesthesia for. And then we take all the eggs that have grown, we take them out, and then we have them in the lab, and we can combine them with the sperm cells to create embryos. And without getting into all the details, if things go well, you don't just get one healthy embryo to work with. Hopefully you get a bunch. That isn't always the case, but if things go really well, you hopefully will get more than one. And so what that basically means is that you now have embryos to return to your body. Each embryo, if it's healthy, should have a pretty good chance of working. And if you have, 2 or 3 or 4 embryos and you use one and it works, you can save the leftovers. And the leftovers are super duper valuable, because it means you can have potentially a second or a third child from that same IVF cycle years later if we freeze the embryos and hold on to them. So IVF can be very, very powerful in maximizing the chance of pregnancy in general, but also even having more than one child from one IVF.
Right. So basically, we're doing shots for 10 days, every other morning coming in to be monitored. You're checking the blood, you're checking the growth of the follicles, of the egg follicles.
Yeah. Yeah.
And once you see that they're a certain size, right? A certain amount of them are a certain size, you give you want to tell them about
you got it. You're doing great.
Okay.
I mean, basically we use those monitoring. We use those monitoring data points to decide when things are ready, and then we do what we call the trigger injection, which gets the eggs ready to come out, and then we schedule the procedure to take them out.
And that procedure is very, very time specific, right? With the trigger shot.
Yeah, I mean, I think we probably overdo it, to be honest with you, but it's definitely time specific. So, if someone's 20 minutes off, that's fine. But if someone's like 4 hours off, it can mess things up.
I was 4 hours off because I had to do it at 2 o'clock in the morning and did not want to wake up my nurse at 2 o'clock in the morning.
Yeah.
So my husband tried to do it ourselves, did not work out. We could not figure it out. Ended up being on her door 2 o'clock in the morning. Called,
oh my goodness.
Didn't answer the phone. And I ended up calling my doctor. She helped me through it on the phone, and I figured it out in the car at like 3 o'clock in the morning. So yeah, we had to.
And it still worked out.
That worked out, but we had to move my retrieval.
Yeah. So
that you come in for the retrieval, you get anesthesia, and the eggs are taken out.
Yep, you got it.
Now they grow. Do the doctors give any updates on the growth of the embryos?
Yeah, so there's a lot of numbers in IVF. And so usually the day of the retrieval, you already can find, at least in our place, and every place can be a little bit different of how the communication goes, but in our place at Extend Fertility. So you find out how many eggs we were able to retrieve, typically before you're walking out the door the same day. The next day, they're evaluated for fertilization, which means they stick all in the lab. They stick all the eggs and sperm together. They make pairs, but unfortunately, the name of the game in IVF is that there's attrition. There's loss at every step, meaning some don't cooperate. So even if you get 20 eggs, you may only have 15 that actually fertilize successfully, and that you would know the next day. And even if you have 15 that fertilize successfully, they then have to grow for typically 5 to 7 days to become what we call blastocysts, or fully developed embryos. And let's say from 15 fertilized eggs, you may only have 7 or 8 or 9 that become embryos. So there's a big step down from the number of eggs till the number of embryos that you have available. There's another thing, which is probably for another session, to talk about the details of something called PGT, or pre-implantation genetic testing, which is basically our ability to biopsy and do genetic testing on each embryo to verify its health before we would then go and use the embryo to return it back in the body. That doesn't always need to be done, but more and more it's done quite routinely.
Is it done with secondary infertility or less likely?
So plus and minus. I don't think there's a specific aspect of secondary that would make us be more inclined to do it, other than age, which is to say patients who are in their mid-30s and older, it's very compelling that it makes sense to do genetic testing, because at least half, if not more than half, of embryos that are made are actually, even though they look normal under the microscope, are not genetically capable of becoming a pregnancy. And so not wasting your time and effort and energy transferring embryos that are not viable genetically is a good thing to kind of weed out the sort of imposters. Right. For patients in their 20s, most of their embryos are going to be healthy. And so the need for genetic testing is less. It's not zero, but it's less important, I would say.
Right. And especially if someone had a child before.
That also affects kind of the decision making. But in the end of the day, that's definitely a personalized decision that would have to be something you would talk about with your doctor to kind of understand the potential benefit and also the limitations of doing this extra testing.
And then once the embryos are either tested and then frozen, or like, what's the difference between a fresh versus a frozen cycle?
Yeah, that's a great question. This is something that really has changed a lot, even in the last, I'd say, 5-7 years in the world of IVF, which is that more than 10 years ago, maybe 15 years ago, the vast majority of IVF was what we would call a fresh transfer, which is to say, you do everything we just did. We get the eggs to grow, we take them out, we make embryos. And then once we see we have an embryo that grew, we put it right back in. If we have extras, we freeze the extras, but at least one of them we're putting in fresh. These days, we almost never do fresh transfers because there's a few reasons, but one of them is that there's been studies that have shown that all else being equal, if you put the embryo in immediately, or if you wait and put it in the following month by freezing it, the woman's body is probably slightly more receptive, more willing to accept the embryo, not the same month. That month, she's taking all this medicine, she's got a lot of eggs that have grown, the hormone levels are all crazy, and the body doesn't like that. And so you're more likely to have success to get the embryo to stick in a month where we've allowed things to go back to normal, for all the hormone levels to kind of become more normalized, and the implantation rates are probably slightly higher. Also, if you're doing genetic testing, you have to freeze the embryos. It's not even a question, because it takes too much time for the genetic testing results to come back to do a fresh transfer.
Right. So yeah, I did a fresh transfer. It didn't work. So I guess what you're saying, yeah.
I don't know if that's the reason, but most programs are doing mostly frozen.
Then I did frozen
mostly or
the frozen cycle worked.
Yeah. So we, as a general rule, again, and it doesn't mean it's the way everybody does it, but at Extend, the default is a frozen transfer. We only do fresh transfers in very special situations when there's a specific reason to do that.
Okay. In any cases, are they secondary or?
Lots of times basically, I think that consideration is mostly regardless of whether it's secondary or primary infertility. Okay. The rationale to do frozen transfer still holds in both situations. Yeah.
Got it.
Yeah.
Okay.
Yeah.
And then we spoke about that already. Okay, so should I open the floor to questions?
Yeah, let's do it. I'm talking too much, probably.
No, not at all. Does anyone have any questions?
Oh, my wife just wrote, "What time are you coming home?" No, I'm kidding.
Extend is number one.
Oh, we got a fan there. I'll just say one more thing while we're waiting, if anyone wants to throw in questions. So, there is the whole world of genetics has changed a lot in the last 10, 20 years because we've learned so much new stuff. And so one of the things that I think have become more clear is that there's a lot of genetic diseases that can be carried. And historically, the notion has been that it's more common for us to find an issue with a genetic disease in a couple in Ashkenaz Jewish background, which is actually true. It is more common for us to find genetic issues in Ashkenaz populations, but it's definitely also true that it's not found in Sephardic Jewish people. So the point is that this concept of doing genetic screening to check if there are any genes that run in the family that might affect the health of the children is something that is relevant for Sephardic patients as well. No one's obligated to check their genetics.
But when should they check their genetics?
So the truth is, for that kind of thing, ideally even before they get pregnant the first time. Okay. And then some people say, well, okay, well, I have a healthy baby, so now I know I'm fine. But even that's not true, because some genetic things have a chance of being passed down to children. And just because you have one or two healthy children, maybe you got lucky, right? And that sounds facetious, but it's not. And so it's not imperative and required that every single person check their genetics, but it's still a relevant consideration to think about genetics, even for secondary fertility, even if you please God, have healthy children.
Someone just asked about, is genetic screening a one-time deal, or should it be done before every pregnancy?
So the genetic screening for these kind of things that we're talking about, the answer is mainly your genes don't change. So in theory, it should be a one-time deal, meaning if you did genetic screening and you're not carriers for anything you have to worry about, then you're good. The only caveat there is that because science is moving fast, every few years they're adding on more diseases to the list. And so technically there may be new things that were added since you got checked, if you got checked a few years ago, but it shouldn't change. So if you did a full panel of genetic testing in the last 5-7 years, you probably don't need to just repeat it just because it's changed. But if you've never done it, or if you did it more than 10 years ago, then it's probably worthwhile to update that. Yeah.
Okay. Someone's asking, when should I start thinking about my fertility?
So that's a big question. I think that it's important for me as a specialist to say women shouldn't, and it's usually the women don't need to be walking around being afraid of fertility issues all the time, right? Like at the end of the day, most women are healthy, most of them get pregnant easily. And so it's not the case that once you turn 18, and you're still single, you have to worry you can have fertility problems. I don't think that's a wise or fair approach. I think the answer is that if you're still single, then you should be thinking about your fertility in the sense that it's a function of your health. And so like everybody should be healthy, and fertility gets included with that. If you know you have gynecologic issues, then it's something you probably should talk to the OBGYN about, if you don't have regular cycles, or if you know you have endometriosis or other gynecologic issues. There's a whole topic for another night called egg freezing, which is something that if you're getting to your late 20s or 30s and you're not ready to start your family yet, egg freezing is a way to deal with the biological clock. If you're sort of just in life, you're not ready to start a family yet. I'm not even going to go there because we can spend another hour on egg freezing. For a couple who is newlyweds, you don't have to worry about fertility straight away, but then you go back to the parameters we were talking about before. If you're trying and it's not happening easily and you're wondering why, it's better to kind of be proactive and start doing some testing, even if it's with the OBGYN, than to just kind of hope for the best or sit at home worrying about it, but not doing anything about it. So, it really depends on where you're up to as far as when the right time to worry is.
This is a good question. Can miscarriage still occur with IUI and IVF? Even if you do PGS, PGD, all the testing possible?
Right. So the answer is definitely yes. With IUI, it's probably no less likely than with non-IUI pregnancies, because IUI itself does not directly reduce the chance of miscarriage at all. With IVF, exactly like you're saying, Laura, if you did genetic testing of the embryo, so that one of the most common, depending on the population, maybe the most common reason for miscarriage is that the pregnancy is not genetically healthy. If you do genetic testing of the embryo to pre-test it, you've already identified an embryo that's not genetically healthy. So that does reduce the chance of miscarriage once you get pregnant, but it doesn't reduce it to zero.
Genetic testing only testing chromosomes, not, it's only testing the chromosome, right? So it's not
So
everything.
I'm probably confusing things a little bit. Let me try to clarify. There's one bucket, one category of genetics in the world of fertility that's like, does a mom or a dad carry a gene they don't want to hand down to a child? That's like the genetic screening that you might want to do, you know, even if you're Sephardic, that's what we're talking about with that subject. Then there's another subject of genetics, which is that every human being, man, woman, has some eggs or some sperm that have a broken chromosome, like you're talking about. And that's inherently part of why fertility doesn't always work, is that that particular egg, that particular sperm might not be healthy. It has a broken chromosome. Even if we make an embryo that looks normal, it may still have a broken chromosome and it's not going to work. So if you do genetic testing of embryos, you can rule out or you can identify the broken chromosomes. By doing that, you will reduce the chance of miscarriages that would otherwise have happened because of broken chromosomes. So it does reduce the chance of miscarriage, but it doesn't reduce it down to zero. There are still miscarriages that are from pregnancies or embryos that are genetically normal. There's other reasons for miscarriage that are not genetic. So it doesn't eliminate the risk of miscarriage.
Got it. Okay. Can endometriosis have anything to do with recurrent pregnancy loss?
So that's a specialized question. So number one, endometriosis, just to level set, is a relatively poorly understood condition of inflammation that is a purely gynecologic condition. And it can affect fertility in several different ways, but the chronic inflammation can basically do things to the uterus or to the ovaries that can make it harder to get pregnant in general. There's a lot, we could do a whole hour on endometriosis, but just for definitions. Recurrent pregnancy loss definitionally is someone who's had at least 2 or 3, but even really 2 miscarriages in a row. And so my main answer is that there isn't a strong link between endometriosis and recurrent pregnancy loss. It's not one of the main things that we know can cause recurrent pregnancy loss. So for the most part, we don't expect endometriosis to cause a lot of miscarriages. Is it possible? Maybe it's possible, but it's not one of the top items that can explain recurrent pregnancy loss.
Okay. Do both partners need to have their genetics checked? Yeah.
So kind of. If you check one partner and they're not a carrier for any genetic issues, then technically you don't need to check the other partner, because even if the other partner is a carrier, the issue is when they're both the carrier. So if one has nothing, then the other partner doesn't matter if they're a carrier. Realistically, we often just do it together because it's also very anxiety provoking. If you check one and they are a carrier for something, then you have to call in the other partner and get them checked, wait a few weeks, get the results. It's just like, so it's certainly inefficient at the very least to do it separately. So practically most people just do it together, but technically you don't really have to.
Okay. And is a woman born with a certain amount of eggs that I guess that she will have for her whole life?
The answer is yes. So going back to the general topic of age and fertility, women are born with their lifetime supply of eggs. It's different than men. So little baby boys are born with no sperm at all. The sperm making capacity gets activated at puberty, and then men are sort of part of a male human body's function is to make sperm. And so men are making new sperm all the time, which is why a guy who's 50 or 60 or 70, if he has a younger partner, it's not such a big miracle if they can get pregnant. Whereas on the female side, women baby girls are born with their eggs already pre-made inside them, and they sit in storage and they age in storage, and something bad happens to them in storage over time. And actually that bad thing is 2 things. One is that eggs are dying off constantly. So you start off with a lifetime supply of eggs and you end up eventually with none. None is why there's such a thing called menopause. Menopause is when a woman stops having cycles because she stops ovulating because she has no more eggs left to ovulate. And that happens to every woman. It's a universal thing.
One egg basically dies unless you get pregnant.
Well, it's more than that, actually. Every month, one egg is released for the possibility of pregnancy. But the truth is, more than one egg dies every month, even though that sounds bad. But remember, you start out with millions of eggs, so you've got plenty. And so, yes, eventually you're going to run out, but you are losing more than one egg at a time. That's important for me to emphasize, because if you make the mistake, which is one of the most common mistakes, of thinking that it's only one egg per month. So some people say, okay, well, I can go on birth control, right? And that suppresses that one egg, that ovulation, that one egg from being released. So I'll save up my eggs, right? Because I go on birth control when I'm 20, and then if I come off when I'm 35, I should have all my eggs like a 20-year-old. It's not true. Whether you're ovulating or not, those eggs are dying off in the background anyway. And so that loss of eggs is something that is sort of inescapable. That sounds kind of gloom and doom. It's not necessarily terrible, just the natural way the body functions. But that is one of the things that happens that makes fertility harder as you get into your mid and late 30s and older. And the other thing that happens, I already said before, is the egg quality issue. Is regardless of how many you have left, you also have fewer healthy ones. And so inherently, it's expected to be easier to get pregnant in your 20s and harder to get pregnant in your 40s because, again, you only get one per month. And the chances it's a good one is much, much higher in your 20s than it is in your 30s or 40s. So it's kind of like it's a numbers game. And the percentage of eggs that are healthy is much, much higher in your 20s than it is in your 30s and then in your 40s. So that's the kind of quick and dirty version of how the biological clock works. It's a matter of egg quantity, the amount of remaining eggs, and egg quality, the availability of healthy eggs, even from those that remain.
Okay. Should I do one more question?
Yeah, let's do it. I worry people are going to run out of gas here because after 9, but go for it.
Okay, so how soon should someone try HSG sonogram, and can the dye push out a blockage without being caught on the X-ray?
So HSG is one of the basic tests of fertility. So usually that should be something that's done relatively early in the game. And now, like I get it, it's not a pleasant test, and so people aren't like running to do it. But at the same time, like we don't have 100 different tests to do, and this is one of the 100. We only have like a handful of different tests to do, and this is one of the handful. So I would usually encourage.
Can this test clear it?
So that's the second part of the question, and the answer is we don't. No, perfect. We don't think of it as a treatment, but there are real studies that have been published that show a transient, meaning a sort of time-limited bump in the increase in the chance of pregnancy in the 1 or 2 or 3 months after an HSG. And the thought is that if there's sort of a functional blockage, like a little mucus clot that got stuck in the tube that's kind of clogging things up, when they flush the dye through the tubes, it may unclog that clog, and then all of a sudden you're back in good shape. And I've seen patients who get pregnant a month or 2 after HSG, and there probably is some relationship there. So yes, there may be some benefit to HSG beyond just the testing, but even in a functional way to improve the chances.
Okay, I'm gonna do one more question because I think it's a good question.
Yes.
Someone said a friend of hers is going through diminished ovarian reserve, where, okay, you'll explain what that is. Is there any way to have her daughter checked? Like, is it something that's genetic?
So diminished ovarian reserve is defined as, well, it's generally defined as having a low egg supply. The truth is that if you're 45 with diminished ovarian reserve, that's normal, right? Because the natural history is that you run out of eggs as you get older. So probably, I don't know this person obviously, but probably when we're talking about it, it's at a younger age. Right? Because there are people who, even though they're in their 20s or 30s, actually have an unusually low egg supply. And so that's actually what we would call premature diminished ovarian reserve.
Okay.
There are some specific connections that are genetic when it comes to premature diminished ovarian reserve. So there are specific genetic tests that can be done to look for genetic markers that can explain early loss of eggs. And so that even if you're not worried about a daughter, but should be done anyway to understand what's going on. If those tests are positive, then there's what to talk about. If those tests are negative, there is a loose relationship between the mother's age of losing her eggs in menopause and the daughter, but it's loose, meaning just because a woman may be having a low egg supply at age 40 or 35 doesn't mean that her daughter is going to run out of eggs by age 30 or 35 or 40 unless there's a specific genetic condition that's identified.
Got it. Very interesting.
Yeah.
Okay.
Yeah. Okay. This is like a speed round.
Someone just asked her name. This is Dr. Klein, whoever joined later. Thank you so much for joining us. I hope everyone.
Thank you for having me.
It was very informative. So I just wanted to say the part 2 of our secondary infertility series will be on December 20th with Jennifer Cabasso and Devorah Enton. Make sure to mark your calendars for that. And there's a number of registrations going on right now for support groups and workshops. So head over to SBH Fertility on Instagram for all the latest information, or call anytime at 718-787-1100, extension 517. And
yeah,
everyone calls Dr. Klein if you need him.
I was going to say SBH, like I said in the beginning, but I'll say it again, does an amazing job at supporting their, their community and their clientele. And so definitely, I encourage you to reach out if you have issues, even if it's just you want to like talk things over with somebody. And if you need help and we can be helpful, SBH certainly knows how to find us. So we'd be happy to try to be helpful for you guys.
Thank you so much.
You're welcome. All right. Take care. Nice to talk to you tonight.
You too.
Thanks, Laura.
Bye.
Bye-bye.